Welcome to NeuroNoodle's Neurofeedback and Neuropsychology podcast featuring tech legend Jake Gunkelman. He's the man who has read well over 500,000 brain scans, and Dr. Marie Swingle, author of iMinds. Our goal is to provide information and promote options for better mental health. The NeuroNoodle podcast is supported by listeners and businesses just like you. Jake Gunkelman, how you feeling, buddy?
Okay, enough.
Are you regulated?
I'm modulated. There's no regulation to me. It's all artificial manipulation from.
No, you're a manual. You're a stick drive. You're not automatic transmission.
That's right. I definitely have a manual transmission. I have to transmit it from bottles and syringes and everything into me. So, I've got myself pieced back together. I was a little low yesterday at the end of the day.
Oh, totally understood. Well, you didn't miss much. You've seen a Tua concussion before.
Yeah, and another one. I mean, goodness. If you take a Tinker Toy structure of hubs and spokes, and you randomly just kind of pop out a few, you can reroute around and create kind of a pathway to get from point A to point B through the remaining structure. But the more times you take pieces out, the harder it is. And if you take out a rich club hub, then you may not be functional again.
Could you explain what a rich club hub is? That's a key.
Well, there's a Tinker Toy center and a spoke coming out, and another one going out the other end. That's just a regular hub. But there's some hubs that have lots of connections coming to them. They're then called a rich club hub. And you've got some of them that are, the anterior cingulate is a rich club hub. A bunch of networks hub in there. The posterior cingulate, another rich club hub. For different networks, the network has a rich club hub and then regular hubs and spokes. Now, so you can imagine a Tinker Toy that's a brain structure that's a little complex with some structures that have a whole bunch of things coming out of them. If you take one of those out, then it's like taking out a major intersection in LA. Well, there's a whole bunch of roads that are just fine, but if you can't get from one to the next, take out the Sepulveda Pass and see what happens, So we really end up having an increased risk with increased injury. That's not an additive increase; it's an exponential increase. The Thompson's son, James Thompson, at Penn State, did his PhD dissertation on sports injuries, and the impact of multiple injury is so much more severe. And again, just you're starting to disassemble the networks that operate the brain, and if you take out the wrong piece, you can lose a whole bunch of function. Now, I don't know specifically all the detail of where in his head his spokes and hubs have been damaged, but the lateral
run for the first down and takes a shot at the 6-yard line.
Yeah, the lateral vestibular nucleus, deep in the brain, at the base of the brain, basically, it ends up being where the cerebellum and the brain and the brainstem all kind of come together in that one spot. And that's the spot that the fencing reflex is generated by. It it's one side, not the other. So you get one side that is tonic and pulls in, the other side's extended.
He's
So
not saying a first down there. That's that is the fencing, and then he goes into posturing. How do I phrase that the right way, Jay? What happened here?
well, the fencing posture is flexion and extension. And at that point, after that, you can end up sometimes having seizures or total flexion. But the initial flexion on one side, extension on the other, is the lateral vestibular nucleus. And again, that's the spot that gives you that reflex. It's a reflex that you can see in infants. Where one side contracts, the other extends. They kind of realize where in the brain this thing is that happens when they do the fencing posture. But after that, you can end up having seizure, convulsive moves. You can be tonic only, which is contracted in, or decorticate, which is all rigidity, stiff and outstretched. So it depends upon where else in the brain things have been damaged. But the fencing posture itself is a reflex, the lateral ventricular vestibular nucleus.
Well, I can say the difference between this concussion and the last one, all the announcers said, hey, that's a fencing.
Yeah.
They know what it is now, at least. So hopefully
The level of education about severe brain injuries is stepping up, and you don't want to have to have learned that.
Right.
That should be an esoteric piece of knowledge in like Dirk de Ridder's brain, and nobody else has to pay attention to it. But nah, unfortunately, high school kids, MMA, hockey,
Soccer.
there's rugby,
Yeah.
um, uh, Australia rule football. I mean, there's a whole bunch of contact sports that end up having head injury, and the fencing position ends up being something that people need to know about because it indicates a fairly serious concussion. Now, there are people that have had it that have gone on to not have significant problems, but they haven't had it like two or three times.
Yeah.
So, James's PhD dissertation comes to mind, and you think, well, if this is an exponential increase in actual negative outcome, he's got to think seriously. But it's his choice. I mean, it's all, we put our butt on the line for different things in different ways, and uh, uh, he may choose to play sports until he's disabled enough to not be able to. But at some point, his team may decide that they don't want to risk him too. Who knows?
But I mean,
Yeah.
this has been going on since football started, and you just don't see, or maybe they had the photographers not take pictures of it, but it can't be the first time, showing the posturing and all that. Now with all the cameras out there, you
No,
can't.
no, no. And in other sports, they've known about it for a long time. 2/3 of the knockouts in MMA end up with a posturing.
Yeah. Well,
So,
what they call it, punch drunk? At least they acknowledged it in boxing.
uh, but dementia pugilistica is the formal name. And pugilism is boxing, and boxer's brain is the common name for it. But it's CTE. You're going to find a vascular degradation, ischemic change, really quite extensive in the area.
Yeah.
And if you look at the EEG, the slow edge of alpha, and the alpha itself may slow. If you get to the point of being punch drunk, you also end up having a high probability of having a Parkinson's like movement disorder. And it's not like I'm claiming that Muhammad Ali didn't have Parkinsonism, but
Yeah.
there are a lot of fighters who have ended up with movement disorders. The substantia nigra is the location in Parkinsonism, and for you to demonstrate your first significant tremor, you have to have about 75% of the cells in that damaged. So, it's it probably took a few rumbles in the jungle to
Yeah.
end up having that damage significantly from boxing. But you can end up having, Parkinsonism from chemical exposure as well. And goodness knows there's a lot of information about that at this point. The CDC is actually looking across the United States, and there's belts and zones that end up having a high likelihood of Parkinson's. And TCE, a solvent, is a well-known source of that.
Where does the plaque come from? I know with CTE, you can't really tell till they're dead and you cut it open, but like what's happening? What's the process that you say, oh, there's plaque? Well, what does that mean?
Well, that's some flotsam and jetsam collection in an area that doesn't have adequate circulation and function. In order for an area to get blood flow to it, it has to function, and that makes a demand for flow, and it opens up the blood vessels in the area. But in a concussion, or let's say you slug me in the shoulder. Well, geez, why did you do that? Now my shoulder is going to swell up a little bit, but it can swell out. Let's say you hit me in the head instead. Well, it's going to swell, but it can't swell out. It's going to compress. And what can it compress? Well, all the little tiny blood vessels that are in there are going to have pressure from outside of them, squeezing them. And some of them are going to kink the hose like you used to do when you were a kid. Yeah, well, it stopped the water, didn't it? So you're going to end up with an area that has a decreased flow dynamic, less perfusion, less delivery of oxygen, less delivery of glucose. Those are two things that are really kind of essential for function. And if the area has enough of a loss, you can end up having hypoxia. The area is demanding some flow and there's no flow. At that point, after the trauma, the demand for function, which you shouldn't be doing, is going to cause cell death. Hypoxia leads to glutamate cascade, which leads to cell death. And so that's why with a fairly significant head injury, they'll usually put the person into a deliberate barbiturate coma, letting the brain recover so that they're not doing something stupid like wasting their resources on consciousness, that let the brain recover and then restore the consciousness, take them out from under the barbiturate.
Well, people have to understand, Jay, because I recently understood it just by listening to you on the show. When you get hit in the head, the brain is sloshing back and forward. I believe the term is Contrecoup. Is that
It's
correct?
coup contra coup.
Coup
It's
Contrecoup.
Yeah, and it's a French. So contra isn't with an A, it's with an E. It's a blow and another blow. And there's actually two kind of uh, 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 guesses as to how that works. And let me do some really awful art.
Oh, I
Uh,
love your awful art.
you have a head and a nose, and let's say we get a blow to the head here. One group says that this will be the coup area. The Contrecoup would be on the other side. So one group says your brain bounces back and forth. The other group will say, well, this looks kind of like a satellite dish to me, which is going to focus energy at a distant location. And the percussion on this creates a force wave that focuses on a spot. So the Contrecoup may be focused force. Now, blast injury, you've got a force wave going through the entire brain. It's not like a percussive, a blow to a spot. This is like a head trauma, getting hit with something, but a blast injury, a force wave goes through it and has little micro tears all over. Diffuse axonal injury is what they refer to that as. But the coup contre coup is either the brain bouncing back and forth or a directed, force because of the curvature of the skull, focusing the energy at a distance. Now, does it matter which one of these is correct? No. Does it does it change anything? No. It could be that there's a little bit of both. But again, ultimately, the person with the blow to the head, yeah, is going to suffer two spots that end up having damage, and that's not it's not a good thing. The other thing is with damage, the severity of the injury ends up changing what kind of cells in the brain are damaged. A minor concussion is usually gray matter almost exclusively. The more severe injury includes white matter. And in the EEG QEEG, the white matter is seen as delta, a delta focus or a delta increase after the trauma. And alpha and beta changes are due to the gray matter, which produced them. So you can kind of look at the QEEG and see the probability of how severe the injury was based on how much change there is in the spectra for delta content, suggesting the severity.
ALS and Parkinson's. What I've heard and seen is you'll see football players, anybody MMA, these people that get these blows to the head and they develop these other conditions. Maybe they're genetically supposed to. I don't know, but is there a link to ALS and Parkinson's to getting a lot of brain blows throughout your life?
Parkinson's, probably. Again, we kind of mentioned that the dementia pugilistica and the substantia nigra and the basal ganglia regulate movement in more general ways as well, but and not just movement. It's also cognitive function. So basal ganglia are important for frontal lobes regulation over attention and affect. So
but ALS, no, because you just see a lot of football players that are out there that are getting it.
Yeah, that may be more chemical exposure for some reason than necessarily brain trauma. Early on, there was some flap about what kind of stuff they're putting on the grass in the baseball fields and things like that, but they haven't been able to quote prove anything. But then how that is.
Yeah, the lawyers get in.
You can't even prove the ability to prove anything. So, and in an adversarial condition like litigation, you end up with experts on both sides, both paid highly to have the opinion that over a beer they would agree with each other, but in court they're adversarial.
Jay, when the posturing occurs with Tua, does like the cerebellum, or you're offline, so your operating system is just to its bare bones basics to keep you alive. Can you explain the process of what's happening in there? I don't even know if it's a cerebellum.
Yeah, right at the base of the brain where the cerebellum, there's what's called tonsils that stick down right next to the brainstem in the cerebellum. At the level of the tonsils in the brainstem, you'll have, again, the lateral vestibular nucleus. You have one on one side, one on the other side. And when the head gets hit, when one of those ends up being impacted, that's when you tighten up one side and extend the other. So that particular spot is involved in that posturing. The rest of the damage or impact is going to manifest itself either as a seizure or rigidity. If there's a decrease in cortical function, you can have a spreading depression from a head injury that kind of suppresses the cortical function, and a spreading depression is going to end up looking like decorticate rigidity, very stiff, and other people end up having convulsive activity. So but the posturing itself is at the base of the brain, where the brain and the brainstem kind of intersect, the cerebellum, all of that kind of hooks together in that one spot. And it's, you've got this head on top of this little stick, and you're whapping it around. Where's the torque? Well, it's at that connection between where everything is kind of coming together at the base of the brain. And the brain itself has the helmet and the skull and all of this to hold it, but you're torquing things at the base, and when you torque it enough at that spot, and it's a common spot because, again, 2/3 of the MMA knockouts you end up with posturing. So yeah, it's not just MMA, boxing and MMA. They've gone through footage and classified posturing, not posturing, and it's extraordinarily common.
Dr. Hill said his number one client for head trauma is females playing soccer and the headers that they do.
Yeah, well, headers are, uh, they're cumulative as well, and you can identify the ischemia of the concussion. If they've done headers and end up with a headache, the headache is post-traumatic ischemic headache. You've had a concussion because you end up with that headache. So,
and the pain is because the brain, the blood vessels are.
Yeah, it's ischemia. Migraine ischemia causes the pounding headache of migraine. Post-traumatic ischemia causes the pounding headache after the head injury. Both of them are due to the presence of ischemia.
And to take away that pain with neurofeedback, how does that work?
Well, it takes a little bit of time, but if you let me
Bad art time or
another bad art time.
all right.
We've got perfusion. There's increased perfusion and decreased perfusion. This is 2 and 3 standard deviations of increased perfusion. This is 2 and 3 standard deviations decreased perfusion. This is DC 0 cycles a second, and this is like 40 cycles a second. In the delta band, you actually have positive perfusion, but at about 3 or 4 hertz, it drops into hypoperfusion. At about 11 hertz, it goes up into a neutral positive perfusion, and at about 16 hertz, it goes into hyperperfusion. So the brain in ischemia is hypoperfused. There's not enough perfusion. And if we make a big demand with asking for a lot of perfusion, that's like bring the brain back online too early, and you're going to cause potentially cell death. So you have to be gentle in the reactivation, but you have to turn the area on in order for it to demand some flow, and some flow demand will open up the blood vessels that are ischemic at the moment. So what we try to do is create some of this neutral positive perfusion in the about 11 to about 16 hertz range. And that's the SMR band range, generally the 12 to 14, 12 to 15 range. And it's a neutral positive perfusion. So it's a gentle request for some function. At that point, it'll gently open up the blood vessels over time, like a root on a sidewalk. It didn't break it on day one. It takes time to open everything back up. And we usually see significant clinical improvement in 12, 15 sessions. Sometimes you have great responses earlier. Those are called session effects. You haven't learned how to operate it properly yet, but the effect of the session was very positive, and you get a very good outcome. Kind of like taking the right dose of the right medication for a time. But it was only a dose, so you haven't learned how to do it yourself yet. But 12, 15 sessions of SMR training usually start to have a positive enough effect on the head injury that it's pretty irrefutable that it's the right thing to have been doing. And SMR style training quite often requires a counterbalance. You can become under aroused training SMR, but the perfusion fix for ischemia is basically to get rid of the hypoperfusion where you see slow alpha and slow it into the theta band. Sometimes it's so slow. Again, post-traumatic ischemia is slowed alpha. So training this faster 11 to 16 band opens up the blood vessels. Anyway, that's the bad art for that.
You are the Picasso of neurofeedback, Jay. So
I've seen second graders that do better art than this, So
your art is magnifique. So Tua, what are they gonna be? He's $1 million athlete. He's got all the services in the world.
I would look at his EEG carefully and figure out what areas have been damaged from ischemia, and I would train those areas to open up the blood vessels so they can recover the function. And to the extent that they can, if you put them back together so that his EEG looks relatively normal, and I can show you before and after, ischemia pre-post treatment, the effect is really quite noticeable. You might have an alpha peak with a secondary peak at 6-7 hertz. Well, that slowed 6-7 hertz alpha peak is slowed alpha. It's in the theta band, but after the training, that's gone. And the alpha peak remains, but the slow alpha is gone. So you literally can open up the blood vessels and restore that function if the area hasn't been totally damaged. To the extent that there's white matter damage, it's harder to recover that, but it is recoverable. Mario Beauregard, Montreal Neurological, had a couple of studies where he showed white matter and gray matter changes with neurofeedback. And, silly me, that this is 2 academic papers talking about white matter change with neurofeedback, but I was still thinking white matter was kind of like permanent wiring, and yeah, you could train the gray matter. It was plastic, but the white matter was kind of static. And until I saw the diffusion tensor imaging changes in Dr. Pineda's study with autism, it didn't really strike me that it was something that training could affect. But it's like the training sculpted the white matter. It was astoundingly potent. So even with white matter injury, but if you have white matter injury, unless you recover it, it's going to have not only the white matter that was damaged is lost, but you have retrograde degeneration. The white matter that's hooked to the white matter that was lost dies off as well. The entire networking And that takes 6 months to a year, and that's progressive loss of function. So either you get in there and you fix the white matter problem and recover, or it degenerates and the network that it was hooked to degenerates as well. So it's important to get in there quick and assess everything and get the training and treatment going. The dog's resetting here.
That's fine. So,
bouncing the computer all over.
What is the fancy neurologist going to do for him? They're not going to look at the EEG for that. They're going to look for what, a seizure or what?
Yeah. Well, there's a difference between neurotherapy and conservative interpretation of epilepsy and encephalopathies, which is what the EEG is limited to in the hands of traditional neurology. If you give me the EEG and only give me the age of the patient, I describe the patient's neuropsychological presentation to you. And if you ask a neurologist, can you do a neuropsychological interpretation on this patient based on the EEG, they'll say no. And for them, the answer is no, they can't. But they haven't learned how. It's unfortunate, but that's, there are neurologists and psychiatrists that have gained the skill set to be able to do that, but it's extremely rare.
I mean, are they just going to do an fMRI? Am I saying that right? fMRI?
Yeah, fMRI looks at the function, but it largely tracks metabolic function, the bold, the blood oxygen level, and it tracks function generally. But if you say my frontal lobe is hypoperfused because of a fMRI saying that the frontal lobe's not on or not active, that's like one thing to them. I can look at it and say, well, that's actually theta, limbically generated theta, which is a dopamine related feature. I can look at it and say if it's slowed alpha, which is a norepinephrine related feature, or just plain alpha, which is serotonin related. And very different interventions. They see one thing, I see three. It's unfortunate that psychiatry doesn't really focus on the brain function. That they listen to a story and come up with a diagnosis and pull the list of meds that they can give for that diagnosis, and then they try one, and if that doesn't work, they try another. If that doesn't work, they try another, and meantime, the patient's got withdrawal and lack of treatment. If you actually look at the brain function first, it can guide your medication choice. I just gave a lecture sponsored by the Korean group. It was translated into Portuguese, and it was pretty well attended, about 100 people, and we talked about the long list of meds that ADD ADHD can be given, and you saw that. It's a long list, but you can pick which one's going to likely work if you look at the brain function. That list is trimmed down to the right choice based on looking at the brain function.
Jay, we'll close out the show on this. If we could send this to Tua's agent and Tua himself, what would be your advice? Because he's got all these $1 million accessories that are telling him what to do. What would you tell him to do? And we'll close out.
Well, if he had an EEG recorded, I'd be more than happy to take a peek at it. You know me, I'm retired. I don't charge for this kind of stuff, and so he wouldn't be paying another $1 million.
To come down first?
No, I get the recording now.
Okay, got it. Okay,
and take a look at the recording, and it'll tell you exactly what and where things are involved, and we can intervene in those locations with training. But he's got a bunch of people around him. It's not like football people don't know about neurofeedback. There's quite a bit of brain.
Kirk Cousins is a fan, and
Yeah,
there's others, but Tua is
yeah,
the one that if he's being told he should be looking at everything if he wants to stick around because he's going to go back in.
yeah. I don't blame him. I mean, you're. uh, when I was younger, I would have done damn near anything to keep going on what I was into, and goodness knows, at this point, I've got everything broken and busted. But I wouldn't have changed a damn thing, so yeah,
All right, I'll see if Tua's able.
I would expect him to get up, dust himself off best he can, do whatever rehab is required of him to get back on the field. And nowadays, it's not just that you want to go back on the field; you
Right.
got to pass muster. And they probably have neurologists and looking at traditional, EEG features, but again. There's a difference between a neurologist and an electroencephalographer, and an electroencephalographer has a year and a half or more of training. Neurologist has 6 months or less of training, and it shows. So
Well, I'll reach out. Let's see if they respond because they had to have done an EEG, right?
I would hope so.
Yeah. Okay.
They'd have to have. Well, in a in a rational world, yes. But
Okay.
are we in a rational world here, Pete?
It's just money. He's got it.
Well,
Um,
it isn't, money doesn't necessarily get you good advice always. It can sometimes obscure,
opinions.
yeah, you know, sometimes more data is just obfuscation,
Yeah.
so.
And then Jay, a reminder, every Wednesday, 6 p.m. Central, 4 p.m. Pacific, we get together with a hell of a group of panelists to take
Yeah,
questions from the audience. Joy Lunt, we got Joshua Moore, we got John Meckert, we got Dr. Andrew Hill, of course, Jay Gunkelman, Marie
we
Swingle.
we have a panoply of opinions, and and educated opinions, not always the same opinion,
Right.
but at least a well enough educated opinion to have a little back and forth on a topic that can illustrate some current thoughts.
We give you enough.
It's important to bat around ideas, and you can't bat them around with one person. Having a well constructed group like that ends up, I think, being a really nice forum.
Well, we give you enough ammo to go to your primary care physician, mental health expert, and give him a hard time based on what you heard on our show.
You're gonna get a hitman sent out
Uh,
at me.
that's me and Trump. And then
So,
October next month, Jay, we have the what?
uh, well, Suisun Summit. As you can see, I'm a freaking mess. I can't travel. I'm leaking cerebrospinal fluid out my nose. I can't fly. I can't take an elevator more than 3 floors up. And so I have a birthday coming up on October 12th, and as a treat for me, there's a group that organizes an EEG meeting here in Suisun City, a town of 29,000 people who doesn't. There's no real reason for an EEG meeting to be in Suisun City other than it's my birthday and I can't leave. So, um, but we've brought in some luminaries and over the years, and Yuri Kropotov this year, the head of neuroscience for the Soviet Union when it was an intact union. Now the head of neuroscience in St. Petersburg, the Institute for the Human Brain, and also in Trondheim, Norway, professor there of neuroanatomy, neurophysiology. We've got Antio Martins Muro coming over from London Scientific, Santiago Braun from Singapore. We've got people from Europe coming over, people from all over the U.S., from South America, from Canada, and one from North Dakota. So, but we all pop in. We take over the yacht club.
Mono Yacht Club. That's right. Best part of Suisun City.
The event caps out at 80 people. We thought it was going to be 70 because of the size of the audiovisual in the back, but we shrunk that down. So that I think they opened up another table, line of tables for 10 more folks. But the live stream for people who can't attend and want to catch the content is available, and the live stream will be shown in the bar at the yacht club for those who hang out in the bar. And that's entirely possible. We are playing musical chairs this year because we're live streaming it. We want people to be seated when we start. And we have a break between speakers so you can actually digest what you just heard and kind of reset for the next talk. And we'll play music to indicate that everybody has to come back to their chair. Music picked for the event, a talk about medications. It could be Mother's Little Helper from the Rolling Stones, So, but it will when the music stops, you can't go into the room because the video is about to start. And if you want to watch what's going on, it'll all be on the big screen in the bar. So we won't cut people off from being able to see it, but they won't be in their seat in time. They musical chairs this year. So keep people from walking across and blocking the view, So.
Well, you got to work on that respiratory, Jay. You got to blow out all those candles.
That I don't think anybody would ever eat a cake that ended up having somebody blow out 75 candles on it. And when my dad, I think he was 65 or something at the time, and they put enough candles to do that, and there's this flame jumping up above the cake. I thought we were going to have to bring a fire extinguisher in, but so at 75 candles, they'll have a 7 and a 5.
Okay.
And they may not be, it might just be a 7 and a 5 without something being lit even. Nobody wants somebody blowing on something they're going to eat nowadays. So,
Jay
and the event is a masked event because I'm at risk for catching anything and having it go straight into my brain. So everybody's masked inside the lecture hall, not in the bar, but in the lecture hall. And we've done it a number of years now, and so far nobody has done a transmission of anything at the meeting. One person did catch COVID on Saturday night when he went to one of the local bars. Sunday morning, he just didn't feel well enough, and he went home instead of coming down to the group meeting. So, but we track where people are sitting, and if somebody catches something, we notify the folks that sat around them. And anyway, we're doing it as responsibly medically as we can as well.
Duly noted. Jay Gunkelman, another Tua Concussion, another NeuroNoodle Neurofeedback podcast.
Well, best of luck to Tua, and as I say,
2 concussions, 3 concussions, 4.
Yeah. Well, with any luck, he'll piece himself back together and have a full life. I wish him luck. Catch you later.
Take care. Have a great weekend.
Bye-bye, Pete.
The NeuroNoodle podcast is supported by listeners and businesses just like you.